Good afternoon. Thank you for joining us for the webinar, Community Supervision Agencies and Collaborative Comprehensive Case Plans. My name is Mark Stovall. I'm a policy analyst at the Council of State Governments Justice Center, and I will be moderating today's webinar, which is hosted by the National Reentry Resource Center. To give you an overview of today's webinar, first we will provide some background on the Bureau of Justice Assistance, the Council of State Governments Justice Center, and the National Reentry Resource Center. Then we'll provide an overview of the Collaborative Comprehensive Case Plans web tool. Then we'll hear from Miguel Avila and Juan Garcia from San Joaquin County, California, about how they develop and implement case plans for participants in their program, Assisting Reentry for Co-occurring Adults Through Collective Support, or ARCS for short. And at the end of the webinar, we'll have time for questions and answers. So for introductions and who's joining us for the webinar today, we're excited to have two speakers, Miguel Avila from the San Joaquin County Probation Department and Juan Garcia from San Joaquin County Behavioral Health Services. And unfortunately, Andre Bethia from the U.S. Department of Justice's Bureau of Justice Assistance is unable to attend. For the biographies of our speakers, Miguel Avila is Senior Deputy Probation Officer at San Joaquin County Probation Department. Miguel has been with the department for 16 years. He has worked in both adult and juvenile fields, and he has had previous experience with juvenile mental health caseloads. He received his BA in Criminal Justice from California State University, Stanislaus, and an MBA with a specialization in dispute resolution from National University, and he is a native of Stockton, California. Juan Garcia is a mental health clinician, too, at San Joaquin County Behavioral Health Services. He conducts intakes, screenings, assessments, and treatment planning with participants while in custody, and supports participants with a community reentry plan upon release, and follows them throughout their probation period. He also facilitates the cognitive behavioral interventions for substance abuse and seeking safety groups in both English and Spanish. Previously, he was the program manager for a mental health program where he provided services primarily to the Spanish-speaking community. Juan received his BA in sociology and his master's in social work. Juan is also a native of Stockton, California, and thanks to both of you for joining the webinar today. And before moving on, I want to mention a few housekeeping items. At any time during the webinar, you can ask questions by typing them into the Q&A panel on the bottom right-hand portion of your screen. This includes both technical and content-related questions. We will try to reply to the technical questions in the chat window as we go, and for the content-related questions, we will keep a running list and address them all at the end of the webinar. We will try to do our best to get through as many questions as possible. If at any time you encounter technical or audio problems during this webinar, please call WebEx Technical Support at 1-866-229-3239. Please understand that there are some technical issues that you may not be able to resolve. For this reason, we are recording the webinar, and we will post it on our website at csgjusticecenter.org/NRC. We should have the webinar posted online by the end of the week. And to tell you a little bit about the Bureau of Justice Assistance, they are funding this webinar generously. And to give you an overview of BJA's mission, BJA helps to make American communities safer by strengthening the nation's criminal justice system. BJA's grants, training and technical assistance, and policy development services provide state, local, and tribal governments with the cutting-edge tools and best practices they need to reduce violent and drug-related crime, support law enforcement, and combat victimization. And then to learn more about BJA, you can visit their website at www.bja.gov or follow them on Facebook or Twitter. And now for some background on the Council of State Governments Justice Center and the National Reentry Resource Center. The Justice Center is a national nonprofit, nonpartisan organization that serves policymakers at the local, state, and federal levels from all branches of government. Staff provides practical, nonpartisan advice and evidence-based, consensus-driven strategies to increase public safety and strengthen communities. And on this slide, you can see some examples of the publications we've produced over the years in areas such as justice reinvestment, reentry and employment, behavioral health, school discipline, and reentry. The Justice Center operates the National Reentry Resource Center, or NRRC for short, in partnership with BJA. Since 2009, the NRC has provided technical assistance to more than 600 grantees. The NRC also serves as a source for user-friendly, interactive information on best practices in reentry. We're always adding new content to our website, and we send out a monthly newsletter that provides information about the latest research, funding opportunities, webinars, and other news about reentry. To sign up for the NRC newsletter and other newsletters, please visit the link on your screen at the end of today's webinar. And now I'm going to give you an overview of our web tool on Collaborative Comprehensive Case Plans, or CC Case Plans for short. So the web tool was launched in October of 2017, and it was created to serve as a one-stop shop for information on developing and implementing case plans that balance risk and behavioral health needs, something that has been a challenge to the field in the past. The tool builds upon a publication we produced called Adults with Behavioral Health Needs Under Correctional Supervision, which was designed to be a tool to help systems plan for matching and prioritizing supervision and treatment services for different groups of individuals in order to reduce recidivism and promote recovery. The framework within that publication shows how to identify groups of people for supervision and programming based on their criminogenic risk, their substance use need, and their mental health need. And so when conducting assessments, ideally agencies would start by conducting a criminogenic risk assessment to determine whether a person is low, medium, or high criminogenic risk. Then a substance use disorder assessment to determine the presence and severity of substance abuse, and then a mental illness assessment to determine presence and severity of mental illness. And after conducting those assessments, that gives you 8 different groups of people, as you can see in this graphic. And so group 1 on the left-hand side requires a minimal amount of supervision and services. Groups 2 through 4 are not likely to recidivate because they are low criminogenic risk, but they do have behavioral health needs that should be addressed through treatment. And people in these groups could be good candidates for diversion programs. And then on the right-hand side, groups 6 through 8, people in these groups should be the target for most reentry programs for people with behavioral health needs. They have the highest need for supervision and cognitive programming, as well as treatment for behavioral health needs. So this framework tells you what to do at a conceptual level in terms of matching resources to the level of criminogenic risk and behavioral health need. And with our CC Case Plan web tool, we wanted to make this tool very implementation focused. And so the graphic of the colored wheel that you see on your screen now, this gives you examples of how different agencies can take the lead in the case planning process and how they can coordinate with other agencies and entities in the process. And from the field, the most common examples that we've seen are a community supervision agency, such as the San Joaquin County Probation Department, or a correctional facility, whether that's a jail or a prison, or a community-based behavioral health treatment provider. Those are the 3 most common types of the lead case planners that we see. And then the other agencies in this color wheel that you can see, they are grouped as medical behavioral health care, or they're focused on criminal justice, or social services, or they are the support system for the participant. And then when you click on each agency or entity in the color wheel, you'll see examples of information that the lead case planners should share with those entities, and vice versa. These examples are things that can and should be documented in the case plan to make sure that case plans are as comprehensive as possible. And so, for example, taking a specialized housing provider as an example, if the lead case planner is the community supervision agency, the community supervision agency should share information about the participant's legal circumstances, specific supports if necessary, income, and if the participant will be on community supervision. And at the same time, the housing provider shares with the community supervision agency information about services provided at that housing location, housing rules, including the programming schedule, and updates on the participant's progress. And then taking a correctional facility as an example of an agency that the community supervision agency interfaces with, that agency should send information about the programming that was provided pre-release, screening and assessment information, medical status, including medications prescribed during custody, and the participant's legal status and history, including any disciplinary issues while incarcerated. And at the same time, the Community Supervision Agency should share information about services that are available in the community and the participant's length of time on community supervision. And so the web tool also has snapshots of 3 grantee programs under the Second Chance Act Reentry Program for adults with substance abuse and mental illness. And the San Joaquin County Probation Department is one of the programs featured on the website, along with 2 others, Franklin County Sheriff's Department in Massachusetts and the Bridgeway Recovery Services Program in Marion County, Oregon. And each snapshot has basic information about the jurisdiction and the program, and then they focus on 3 key areas for collaborative comprehensive case plans, which are interagency collaboration and information sharing, staff training, and screening and assessment. And then on this slide here, you can see just a little bit more information about the program description for each site that is featured on the web page, and information about their screening and assessment instruments and the main interventions offered as part of their programs. And then finally, the web tool has a list of 10 priorities and components for case planning, which you can see here. And these boxes are expandable, so you can click on each area to read more about them and also see links to resources for more information. So after giving you that overview of CC case plans, I'm going to turn things over to Miguel and Tawan to talk about their case planning process.
Hello, how's everybody doing this mid-morning or afternoon, depending where you are in the country? I was wondering if everybody can hear us okay.
Yeah, we can hear you.
Okay, fantastic. I'm Miguel Avila. I'm the Senior Deputy Probation Officer here with San Joaquin County Probation. I was assisting running the ARCS grant while we had it. We were fortunate enough to get a dual diagnosis grant for, how many times did we get it? 4 times? 4 times. So we were very blessed that we were able to get this right and have enough opportunities to try to see what worked and what didn't in our area. We're going to be going a little bit through our program overview on kind of a little history on this, so here we go. So ARCS program, the Assisted Reentry for Co-occurring Adults Through Collective Support. That's the best name we've come up with the acronyms that we have, so that's why that's that. There's really self-explanatory. So this started as a collaborative program between San Joaquin County Probation Department, the Sheriff's Department, and Behavioral Health Services. The program was focused on providing pre-release and post-release services for males and females adults with co-occurring substance addiction and a mental health illnesses that were sentenced to our local facility for a minimum of 90 days and with a minimum formal probation grant of 3 to 5 years. Now, the minimum 90 days is very important for the fact that because we focus on pre-release services, it gave us an opportunity to work with the clients while we had their full attention in the institution. That was the focus for the 90 days behind we did that. The program is voluntary. Everybody who's in our program is there willingly and not by force. It starts after the offender has been sentenced, so they do need to have an adjudication and a conviction. The way this works is that about every month, the classification officer at the Sheriff's Department sends us a list of inmates. We run these inmates to see if they meet certain criteria. The criteria being on our static assessment is their recidivism. So if they're high, medium, low, so we accept all different kinds of clients depending on their needs. So we have the opportunity to override somebody from low to high if we feel that they need more mental health services than probation services, and likewise. Our SRA to do our offenders to see our recidivism is what we primarily use our focus on, and they have to do at least a minimum of medium or high on that for us to even kind of go into it a little bit further. After that, we give an introduction on what the program is, what the program focuses on, which is them, and then they're started off with their HIPAA forms, which gives us release to behavioral health services. This is when all the assessments start, is while they're in custody. We do that assessment. We do the K6 mental health screening tools and criminogenic risk assessment, which is a strong tool. You want to talk a little bit more about what the K6 mental health screening tool is, Juan?
Sure. So I'm Juan Garcia. I'm the lead clinician with the ARCS program here at San Joaquin County Behavioral Health. And so the mental health screening tool that we use is an adult assessment. And in the adult assessment, we actually cover from the general client information to what their chief complaint is in regards to their mental health issue, the history of how long they've had their mental health issue or situation. We're also looking at their strengths. We do a suicidal and homicidal assessment. We cover any previous psychiatric treatment that they may have been involved with in the past, either as children, young adults, teenagers, and now as adults. And then we look at all their history from their upbringing, any placement, their family of origin, their education, work history. And then the assessment also actually goes into their medical history and then substance abuse history. And then we do a mental status exam to kind of look at what their affect, mood, their thinking process is, and then to come up with an appropriate diagnosis so that we could indicate and show that there is a mental health issue as well as the substance abuse issue. For the substance abuse issue, we actually use shorter to ASI, but it's an addiction severity index. And this also looks at a lot of the information that we pick up on the assessment, but it concentrates mainly on their substance abuse.
Yeah, these assessments are super important. Most of the people that we're talking with, most of the clients that we have been undiagnosed or haven't had a diagnosis since they were, or reassessed since about, their teenage years. So some of the people that we're meeting and speaking with and telling them and about mental health and what it really is and the stigma behind mental health is probably been the big push behind us as far as getting these clients to accept that it's not necessarily a bad thing that they need some mental health services and getting past that stigma. During this time also, it's during these 90 days when they're in custody minimum, it gives us an opportunity to build rapport with our clients. The first phases are usually done together with the probation officer and Juan Garcia speaking to them and signing all the liability, let them know as far as the release of liabilities, letting them know how the program's going to be, what's going to be entailed, what's going to be required of them. Not only that, like I said, it takes not only us, but the collaboration of the Sheriff's Department also, which was huge to get a facility to want to participate in this type of treatment for when they they're getting ready to release back for reentry. Because of this, we were very specific with what we wanted from our offenders. We started off with some evidence-based practices. The classes that we chose to go for after the initial phase of enrollment into the program, which is all the assessments, we start off with phase 2, which is the evidence-based programming classes. The programming classes that we went with were seeking safety and CBI for substance abuse, was cognitive behavioral interventions for substance abuse. A lot of these programs focus a lot on the offender and inward reflection. It also has a lot of tips on how to look to the future, look for dangerous situations, things like that, but it mostly teaches them about self, which is what we want them to see, is how this is going to affect them. Juan does an amazing job connecting with the clients. Like I said, that individual 90 days when they are in custody to get the buy-in from the offender to see that this is going to be more beneficial for them. Because it's so intensive, we use a intensive family-based reentry transition planning. What that means is that we just try to reintegrate the offender back with their family. By this point in their lives, if they're usually ready to make this type of commitment to change, they've burned a couple bridges along the way. So our job is not only to show the offender they've changed, but their family also that this is a different individual. Like I said, this process takes in our program, we set a time limit of 9 to 12 months. Obviously, it's going to be going on after that, which way they need to maintain. But the fact that our offenders, our clients see, their families see that we're not in this for our own personal gain, that this is to help them and for services for them, I think it goes a long way in showing what both sides of our profession can really do, you know. So these offenders are with us for about 9 to 12 months. 3 months minimum while in custody, and the rest are an aftercare program. We're going to talk about a little bit about the way that the facility, our county jail helped us make this program successful. Okay, so when we first got our grant, our first grant for, at the time it was called TIGER, Transition Age Youth Guided Reentry Program, the correction officers, at that time there were 11 officers who were strictly working with our program. These 11 officers at the time were interviewed, were trained in motivational interviewing, the K6 screener tool for mental illness, crisis intervention training for law enforcement, and an all-staff adaptation to understand seeking safety as an evidence-based approach. So we not only gave them training, a little bit more training on it, but we really tried to get the staff's buy-in also to understand what barriers mental health can put. And like I said, it's not necessarily a cognitive choice that these offenders may be making. There may be something different. It may be different situations, different ways to approach things. So we were fortunate enough to have the funding to provide these different types of trainings for our officers, which I feel made a huge difference because it did let the officers know that there was potentially something else that could be done or something else that needed to be done differently for change to happen. As far as our clinician, we are fortunate enough to have Juan be the dedicated clinician for the ARCS program right now. He's trained in substance addiction and mental illness to conduct his assessments. He'll facilitate both groups in and out of custody right now because we're kind of jam-packed. He's been focusing all this time at the jail. He runs groups twice a day. What days, Juan?
Actually, right now we have groups Monday through Thursday, and we are in class from 9 to about 12. So we're running 2 groups right now. The first group meets Monday and Wednesday. The second group meets on Tuesdays and Thursdays. And the groups that we're running are the, like Miguel mentioned, the Seeking Safety and the Cognitive Behavioral Interventions for Substance Abuse groups.
This is huge. The Juan being in the facility is huge. Prior to Mr. Garcia being in the facility, there was only one other clinician for the entire jail. So the assessments, to getting the clients what they need as far as medication, any other treatment was almost impossible. The fact that we've had somebody on site now to work with our people specifically, and Juan's running groups of about 10 to 12 people per group. So our caseload for our PO that supervises this right now is, it sits at 28. So it's not a high caseload, but they're intensive, so you can't put that many people in there. But the fact that he's on site at the facility when fires need to put out is huge. I think that's where the main focus of this program is in the institution. As far as the probation officer, there's one dedicated probation officer to the program. This probation officer also been trained in motivational interviewing, evidence-based theory, crisis intervention training for law enforcement. It just gives a little bit more background for our officers. One interesting thing about the jail is that after we finished the first grant, our first dual diagnosis grant, and the officers that were in the wing of the 124, they noticed that incidents against officers were reduced by about 85%. And this, like physical attacks, just any type of incident against the officer were reduced because of the training, of the motivational interviewing, of just the understanding that the officers were able to have. After this initially started, and seeing how that's the way that this field is going, we've since been able to train every correctional officer in our institution, to be motivationally interviewed and trained in evidence-based theory. So this is not something that's just that we've kept isolated to this program. Parts of it that did work seem to expand, not just throughout our department, but throughout other departments that we've been working with. The treatment and case plan collaboration. So the dedicated ARCS clinician and probation officer will conduct the following assessment of the individual offender as a team. All agencies involved in the collaborative program have individual health, insurance, portability, and accountability act forms that the client signs and agrees to inform sharing between involved collaborative agencies. And this is just the HIPAA portion we were talking about. We explained to them and want to explain to them in detail, there's only certain information that I need to know so that they're successful. One is their attendance in the program and participation in the how they're doing the program and if they're going. Besides that, they can choose to check different boxes to let me know if Juan can talk to me about what their specific diagnosis is, what, if any, medication they can take. And like I said, the spectrum of what we ask for, it can vary from just, like I said, participation, but most of our clients don't have any qualms as far as the information that we share between the agencies. They understand that the more information that we have about them, the easier and the better decisions we can try to help them make. So we've never had an issue with our information release. But that being said, like I said, me and Juan, or we used to, talk to them at the same time. As far as we're both in a meeting with them, just with the offender, completing the strong assessment, going over that, completing the addiction severity index, the mental health services adult assessment, and on our end, for the probation department, we would complete what's called our offender's need guide. This is the full assessment. It was easier on our end to do them at the same time, to get the same information. Most of the information that we retrieve for our offender's need guide is the same, most of the same information that BHS pulls for their psychosocial. So it was, for us, easier to ask a question one time as far as where'd you grow up, did you graduate high school, than to go into 2 different interviews for an hour and a half each time. That being said, we did the HIPAA release at the beginning of the interview to understand. So during parts of the interview, if they didn't want us previously to have information as far as what the assessment was, the severity, the addiction severity, we could step out. They can continue that portion of the mental health screener part before we would continue to move forward. But that wouldn't change how the collaboration part worked as far as working in the best interest of the client and what his needs really were. I know you guys probably don't believe this, but behavioral health treatment plans and probation treatment plans didn't always align. The thing that we were supposed, the criminogenic need that we were supposed to target as a number 1, maybe a little bit different than what Juan wanted to target as far as the mental health. Because of the difference in what we were targeting, everybody involved discussed any technical violation about a client, anything that we were going to do with the client, so that everybody was able to have input on decisions and recommendations for the client. So it wasn't just probation's a lead, we're just going to put a bench warrant out because we don't know where he's at. We contact Juan, hey, how's he been doing in group? Has he been attending? Did he miss these last couple of weeks? He's still been having contact with you, not with me. So it was trying to find that middle ground, working with the agencies, and as far as, even though crimiноgenically I felt that anger was his biggest issue, you know, perhaps during his addiction ASI, Mr. Garcia felt that we should, you know, attack the substance abuse first to get him clear-headed before we put him in counseling for anger management or court-ordered programs like domestic violence or anything like that. So having a clinician be able to sit down and tell you, hey, this is probably going to be the better way to handle this because we want him fresh, so that he was able to accept the information instead of kind of zoning out and still being under the influence. So it opened my eyes also, working the collaborative team as far as what limitations each organization really has. If you've never really worked with a collaborative agency, you don't really know what they can or cannot do. Everybody watches movies and has different assumptions of what agencies can do. But in the end, understanding the limitations of what BHS and them understanding the fact that, hey, just because he made you mad doesn't mean we can go the rest of the day. You know, that kind of stuff, you know, understanding that between each agency was huge.
Okay, this is Juan. I'm going to jump in a little bit here in regards to address the treatment and case plan collaboration between mental health and probation. So usually when dealing with this offenders, like Miguel mentioned, the idea is to understand that sometimes either their behavior or the choices that they make they may not be able to control it because of their mental health status. Also, too, if they are using or under the influence, of course, they're going to make you know, bad decisions or decisions that they probably wouldn't have made if they're clear-headed and not substance abusing. The ideal is that in working with these individuals, what we're learning is that because of stigma around mental health, they actually don't want to share what's really going on. It's not until after they're in the class, after a while, which is when Miguel mentioned that the importance of the 90-day, it actually is very important to build that rapport with them, because then you can actually get them to disclose what's really going on in regards to their mental health. We've had a couple of individuals that when we started to educate them about PTSD, realized that when we first did the first screening and interview, they did not disclose a lot of information. So we were actually having some of the offenders requesting to be reevaluated because of the fact that they're realizing, you know what, I need to be honest about my mental health, and they're learning, you know, what it is that they're really going through.
And a lot of the times with our offenders, you know, they didn't know that some of the things they went through weren't normal. Mm-hmm. Unfortunately, and, you know, during some of these classes, you're sitting down, you're like, oh, yeah, no, that happened to me. You're like, oh, well, when? I was like, oh, it used to happen all the time when I was about 10 and 8 and 12, and you know, they've accepted what it is to such an extent that, like I said, they feel that that has just become the norm. So trying to re-educate somebody on actually what, you know, what is quote unquote normal, you know, what you can and cannot deal with. Like I said, the stigma of mental health has probably been the biggest thing that these participants have been able to overcome. The fact that they understand that we're a little bit different, but it's okay because we're getting help and we acknowledge that.
Yeah.
So this is, like I said, one of the most important parts of any type of collaborative program is this here, is that it's very integral, the communication between agencies that are involved. I think a lot of time when we're asked about our program and you know, what has made it work for so long and work well is the fact that, you know, I don't think anybody in this program necessarily sees themselves as a lead agency. There's not one person that really runs this program. We all came to an understanding that this program wouldn't be successful unless we all put in equally to it. And I think that's the biggest part of collaboration, is that understanding that there's not a single lead agency. There's probably one that the grant's name is in and somebody's going to have to do the reports, but that's not what's going to make the program a success. Having that active communication, we would meet every other week with BHS staff, probation, and the jails. And that was just with line staff to see troubleshooting any issues, any specific problem clients, anything that we need to address that way. On a monthly basis, we would have a stakeholders meeting with all the parties involved, as far as all administrators from BHS, probation, and from the jail. So the collaboration is huge. As soon as people start stepping away from the table and you know, taking less interest in it, you can see it started going away. Like I said, the collaboration is huge, and the participation is a must. We're going to talk a little bit about some of the results that we had. We're still working on some of the numbers. We just closed out our grant here in June, officially at the beginning of or end of May. I think we officially closed our grant out. So we haven't got the results for recidivism on this. The numbers that we're going to be looking at right now are from our first Tiger grant, our first dual diagnosis grant that we had. During the first grant, which was Tiger, our program was able to reduce recidivism on this target population, which at this time was 18 to 25-year-old young adults, by approximately 70%. We had a 70% still completion rate or successful rate after 6 months of completing the program. So that's after they're done. When they're done with our program, we try to modify them to informal, if not to a lower level of supervision. And then within those, if it's another study, 6 months, still 70% of them had not recidivated. Like I said, incidents against our staff in the correctional institution who were trained in motivational interview and crisis intervention were reduced by 80%. It helped the corrections administration provide MI to all its officers in the institution. Is there any specific questions that anybody wants to know about as far as the programming or any other assessments that we use? We've completed, as a requirement of our grant, we completed a toolkit, which I think Mr. Stovall said he was going to make available at the end of the presentation here. But this toolkit kind of put everything that we've done to get a program like this off the ground, as far as what partners, helping identify the partners, targeting all agencies, targeting specific things. So if anybody's interested in that, like I said, Mr. Stovall will be able to have that up here later on. But is there any specific questions anybody would like to ask?
Well, thanks so much, Miguel and Juan, for that overview of your program and for walking us through your case planning and treatment planning processes. There have been a few questions that have come in already, and just a reminder to those who are watching the webinar to please chat in any questions in that chat box as you think of them. But one of the questions we have is, can we get access to the assessment and risk tool used?
The assessment and risk, our department purchased the Static Risk Offenders Needs Guide, the STRONG tool, so that's the tool that we use. It's going to be dependent on every department to see what the department's going to want them to use as far as a tool that your department's going to want us to use. But ours is the Static Risk Offenders Needs Guide. And all this information, every assessment that we use, it is in our toolkit. And as far as access, I would love to say yes, but I said I think you have to buy them.
Yeah, that makes sense. And what about the mental health and the substance use assessments?
So the mental health assessment that we use is just an adult assessment that BHS put together. I believe that if, again, I think we have an example of it included in the toolkit. So if you do want to take a look at it, that'd probably be the place to use. The one that we use for substance abuse is the Addiction Severity Index, also known as the ASI.
The 5th edition.
5th edition, yeah. And I believe that's also on the toolkit. And then I've actually been able to just search the web, and they do have examples of these as well.
Yeah, it's not too different from kind of like a normal psychosocial, a survey as far as just getting, you just want to try to get what history you're going to need from the offender as far as whatever name it has. Like I said, Juan was talking about their form. From my understanding, that form was made up by an administrator, umpteen years ago, and they just kind of, it's an internal form that they now, that they've kind of just used, but there are pre-populated forms that you can purchase, I believe.
Okay, great. And then another question that's related to that is, can you clarify the referral process when someone gets into the program?
The referral process, The referral process is dictated by our classification officer at the jail. So everybody who's in our 124 facility, which is our honor farm, everybody who runs to that facility, they get the name forwarded to the supervising officer. The supervising officer then does a screening to see if they are medium to high to recidivate. If they are on formal probation, they need to be on formal probation 3 to 5 years, or in California, AB 109. If they've met that minimum criteria, we have the interview. We let them know about the program, what they need to complete as far as you're going to complete seeking safety in custody, you're going to complete CBI in custody. This is you're going to be supervised for a minimum 9 months after you get out, focusing on, like I said, the treatment plan and case plan, what the goals were for those. And because each one is different and individual, the requirements are going to be different for every client. But our client list comes from the jail. It's populated by the inmates who are in custody who have a minimum 90-day stay. And then like I said, we evaluate them after that. If they agree to participate in the program, we then go back, set up the appointment with the officer and the clinician, and they do, like I said, the full psychosocial, the offender need guide, the addiction severity index, for them to, like I said, meet the further requirements. And like I said, the requirements being they have to have a DSM-5 diagnosis and be on a formal probation grant or AB 109.
Thank you for that. And then another question is, how do you screen for and address trauma in the program?
So we're actually using a screening tool to screen for post-traumatic stress disorder. And we're actually using it's called the TCU trauma form. And it was put together by the National Center for PTSD. It was created by Weathers, Litz, Huska, and Kian back in 1994. But that's the tool that we use. If you have access to the internet, you can actually plug it in. Just plug in TCU TRMA form, and an example of it will come up.
And we've gotten the jail to complete this form upon intake. So when the client comes in for a booking at their intake, the officers are completing this form. Some of them are for our clients. Because most of our people, the sheriff's department, like to the collaborative portion of the program, if they're in there and they need the paperwork, like I said, the jail is getting this done in custody for us. So the TCU is being done by the intake officers in the booking.
Great. And then just to follow up, what interventions are offered for trauma?
So the tool, the interventions that are used are part of the curriculum in the Seeking Safety and CBI groups. Seeking Safety, it actually addresses PTSD as well as substance abuse. And so it's an entire group of classes that addresses trauma as well as substance abuse. And then during the course of the class, they actually learn coping skills they can utilize. They're educated about mental health symptoms, mental health diagnoses, and then they're also educated on the resources that are available to them, whether it be therapy, continued group treatment, or if they even need to be evaluated for any psychotropic medication. CBI as well focuses a lot on the substance abuse issue, but it also does educate and address the trauma that has been experienced by a lot of these offenders.
And those are the only two that are mandatory to complete the program. Our department does have an extensive evidence-based programming classes, so we can put them in social skills, we can put them in ACT, we can address different needs that they have based on their offender needs guide, their O&G, their top 3 criminogenic needs. So if it's anger, we have evidence-based classes within our department to address the anger. Like I said, if it's more a mental health issue, we can refer them just to mental health to go one-on-ones over there if necessary. Like I said, there's a varying degree of things that we can do, but there's only 2 things that we do require as mandatory, and that's the Seeking Safety and the CBI. Everything after that, it's a kind of, we'll see as we go, depending on client needs.
Okay, great. Thank you for that. And then another question is there a continuum or coordination of care for participants in the community who have completed the program?
Okay, so once the participants complete the Seeking Safety and CBI groups while in custody, then the ideal is to work on a treatment plan for their exit upon release. And so the idea is that the clinician, myself, we actually will, as part of the case plan, will follow them, let's say for the remaining of their probation period. A lot of these participants have 3 to 5 year probation periods. Now, if they participate in the ARCS program, then their probation period is greatly reduced. And so for that amount of time, I'll go ahead and follow them, providing them any kind of case management, supportive services that they may need or require once they're in the community.
It's on probation's end also. It's the same thing, you know, even though we try to set up the best we can, and even though you completed the program, it doesn't necessarily mean that we will modify you to inform. If there are other services you need for stability, we do that downstairs in our assessment center. We have Human Services Agency staff to help with housing, food stamps, that stuff. We have WorkNet for employment. And like I said, we all keep this in-house in our building, so it's easy for us just to be like, oh, okay, you need some services? Let's walk right downstairs instead of me having to wait a week to go to HSA, to go to all these other agencies. When we kind of, our department was fortunate enough to bring all these services in. We have offices here in our building for them to use. So that's, the continuum of care continues afterwards. Even though you may finish the class, it doesn't necessarily mean that everything's great. Like I said, we continue to follow the treatment plan, the case plan, and we reassess after 6 months or after any major incident. So if you finish your classes and you finish your program, we'll reassess because the things that you need aren't going to be the same. So we'll do reassessment after a major incident in somebody's life, and like I said, completing one of these programs is. It's a different individual you're usually dealing with. So we'll do that and then continue the program as far as the continuum of care to see what the needs are based after that.
Great, thank you. And another question is, do you track dosage hours for risk level, and how do the interventions integrate with dosage to be provided once the participant transitions to the community?
As far as dosage hours, I think that's kind of something that we've gotten away from here at our department. We focus on the criminogenic needs and not necessarily the dosage hours, but I do believe that with CBI and Seeking Safety, it is over 70 hours or so of dose just for those 2 classes. So just for those 2 classes, you're going to get the clients in our program, the dosage, one-on-ones, everything else. They're probably getting about 100, 125 hours max, hours of dosage for our clients. Now, even if their static risk offenders needs is medium, you know, I think most of our clients, even though we have lows, they'll get overridden, and everybody will kind of complete around about 100, 125 hours of, you know, programming. But we do track, you know, like I said, we have tracked this information. We know if they complete our skills streaming, our social skills, our ACT classes, ART, we know what each one of those classes as far as dosage hours is worth. And we have another program called, we have another program here at the department called the Day Reporting Center, and they're the ones that focus more on dosage hours for their clients. So if somebody did need information on that, I can probably get them a little bit more information on that from our department.
Okay, great. And then another question we have is, how do you put an emphasis on prevention of relapse for participants instead of waiting until there's a danger to self or others criteria before probation takes action?
We emphasize the communication with our clients. I think the biggest effect that we've had in dealing with these situations is to ask the client, you know, because sometimes you don't know what their, you know, factors are. You don't see the risky situation. Sometimes you just get the report that he relapsed, you know. in these situations, you know, we've asked the client, cool, what do you think, you know, what do you think your consequences should be? To put this on the individual, because it's easy for me to, you know, put somebody back in jail or order somebody to complete more classes, but when you include the offender in what the consequences of his actions could be, it's like, what do you think you need to make you better? You know, you kind of try to put it back on them. You emphasize the importance of communication between them. You know, and I tell my clients, there's almost nothing that I can't help you with if you let me know. And that's the truth. There's almost nothing that we can't help them with if they let us know ahead of time. We've sat down, and when that does happen, we'll sit down with the client. We'll do a behavior chain. Here's your choices. Here's what you want to do. Here's what you know you can do, and here's what you need to do. Which one, you know, you sit there and you got to get them to understand that they're not learning anything new. They're just slowing their thought process down and getting to understand the things that they're actually feeling. So I think the 90 days building rapport with them while in custody, like having that time to speak with them, to get to know them, to see that you're in there for their best interest, like I said, just kind of really pushes that communication with them to the point where if you don't call them for a week, they're going to call you and ask you if you're okay. And our clients do that all the time. Hey, I haven't heard from you for a week. Are you doing all right? Is everything okay? You know, it's like, yeah, I'm sorry. I just have 27 other people that we need to look after. I thought you were doing okay. Oh, I am. I was just checking on you. So it gets to that point where they're calling to check on you, you know, as far as the other way around. So, like I said, the 90 days, setting it up, the communication, just really showing these clients that you were there for them. That's what's gonna eliminate all of that. Even trying to figure out when they're going to relapse or get notified after the relapse. They'll start telling you. They'll start divulging the information.
Yeah, and I'm going to agree with Miguel on that because when we're in class, part of the curriculum for both groups is a check-in right before group, and some of the items that are included in the check-in is what safe coping skills have you been practicing? What risky behaviors have you been involved with? And then also if you've had any kind of slip or relapse. And so once the groups start going, you do notice in the participants that they actually start sharing, and they're actually, you know, the idea is that they are honest and sharing whether they're relapsing or not. And then, of course, we open it up to discussion and talk about the repercussions of relapsing. And I know, at least for the individuals while they're in custody, that you know, they're tested on a weekly basis. If they give any reason to even give an idea that they may be using, they're tested. And so, and the aftermath is if they do relapse and they test dirty, they're actually given more time. And so I know that that's something that these participants don't really want because they're already looking at the release date. And you know, the idea is for not to add any more time to that.
Thank you. And a related question is, does probation have a policy or practice for incentives and sanctions? And if so, is that shareable?
Yes, we do. Our department developed a matrix system for incentives and for consequences, I guess. Yeah, so we have, depending on, like I said, if it's a regular formal case, domestic violence has a specific section, and we have it developed from our department. I don't see it being an issue, and I can write this down to provide this information to Mark to get him our matrix. In this specific situation, that's not something that we necessarily go by, just because in a dual diagnosis program or any type of grant program, it's going to be a little bit different than what your general rules are. And because this is a specialized, individualized caseload, there's going to be some exceptions to, you know, following your matrix, you know, like you should. Not that you shouldn't, but like I said, when dealing with dual diagnosis clients, you know, sometimes it's going to be better to have them go speak to the clinician than to go take them to jail for 3 or 4 days. So like I said, even though we do have a matrix, we tend to go on an individual basis specifically for this grant, just because the mental health, the substance abuse, and the individualized treatment plans that we kind of give them.
Great. And another question is, was there an electronic record that was used by the team to input information? And if so, was that record accessible to all team members?
We partnered up with a local agency called Data Co-op. They are our third-party neutral assessor of all our information, all the stuff that we gather. It was. We just used an Excel spreadsheet to track everything that we needed to know about these individuals. Because we had ran the grant so long, we kind of knew what stats we needed to keep. But we did keep a dashboard as far as that we would present every month to our monthly meetings as far as employment, housing, the number, the ethnicity, gender, how many people have completed groups, how many were AB 109 versus formal grant, formal probation, and the custody status of those clients. One person was in charge of the data information. Everybody kind of did their part to gather that information. I know Juan would send me stuff from the clients while in custody, as well as our classification officer who was Officer Hall at the jail. So, but there would be one person that when that was, at the time, that was myself, that was in charge of inputting all the data, keeping all the spreadsheets, and disseminating that information to the group.
Great. And then one last question is, you mentioned that you had a few different grants, and you mentioned that you closed out your most recent one. Were you able to sustain the program? And if so, how were you able to?
I'm glad to say that we were able to fully sustain the dual diagnosis program here in San Joaquin County. Unfortunately, it was with a lot of crying and begging and pleading to our administration. No, I'm kidding. Once our administration saw the effectiveness, I know the numbers are not there. I know that there's only about 30 people at a time that you can help, but the recidivism numbers, the attack against officers, the incidents against officers was sufficient enough that all of our administrations felt that this program was worth keeping and implemented and sustained full time. So now there's another officer who's a fully dedicated dual diagnosis officer. Juan is still the dedicated clinician. Like I said, this is all general funding through each agency. The Sheriff's Department still has their 12 or 13 officers trained in the 124 unit and the classification officer working with us. The Sheriff's Department still is providing all the facilities and services in the jail so that we can run the groups and keep that going, keep the lines of communication open, and just continue to work well. So I think this program was sustained because of its own success, not necessarily because of what anybody individually did. I think just working with this particular clientele base, it's going to take a little bit more people and a little bit, a little bit lighter of a touch. So I think, them seeing all that, that's what led to the success and sustainability of our program. It was just a very well collaborative program, and like I said, something that let our department build on. Because of this program, like I said, we would develop greater relationships with behavioral health to where we have several clinicians in our building now. And like I said, an amazing collaborative partnership with the Sheriff's Department where we have officers stationed at their facility still. So I think just seeing the success of how everybody can work together, seeing how we're all have the same common goal, we all deal with the same clients, it's beneficial that we all work together.
That's great. Thank you for that. And then before we wrap, I just want to mention a few different resources available. The first is the Criminogenic Risk and Behavioral Health Needs Framework. That was the graphic that was in the presentation a few slides before. And then the Collaborative Comprehensive Case Plan web tool. And also a recording of another webinar we did last October on developing and implementing collaborative comprehensive case plans. And then we have contact information for myself and also for Miguel and for Juan for any follow-up questions. And then just a reminder to sign up for the National Reentry Resource Center's newsletter to receive information on upcoming webinars, funding opportunities, and news in the field of reentry. And a very special thank you to Miguel and to Juan for being on the webinar today. Thank you so much.
You're welcome.
Thank you.
Thank you.
Thanks, everyone. Have a great afternoon.